Welcome to today's Cancer Center seminar. It's a pleasure to introduce Dr. Erin Marcotte as our Masonic Cancer Center invited speaker today. Erin is an assistant professor in the Division of Pediatric Epidemiology and Clinical Research in the Department of Medicine here at the U. She received her Master's of Public Health and PhD in Epidemiology from UCLA. Dr. Marcotte joined our faculty in 2015. She has diverse research interests in pediatric cancer epidemiology, including childhood leukemia, hepatoblastoma, and NF1 associated tumors. In an era of increased emphasis on translational research, I find that Erin has an exceptional ability to identify high impact questions. She also has a history of collaborative research with bench scientists here at the Cancer Center. Today, she will be talking about the epidemiology of cancer outcomes among children diagnosed with leukemia and hepatoblastoma. Welcome, Erin.
Thank you so much for the introduction, and thank you for having me today. I'm excited to talk to you about two projects that I have ongoing on survivorship and outcomes among children diagnosed with pediatric leukemia and hepatoblastoma. So first, I will talk about the project regarding hepatoblastoma, long-term survival. We'll go over background, methods, and results, and then I will talk about a project that I'm hoping will start soon on socioeconomic status and acute lymphoblastic leukemia outcomes. So beginning with the hepatoblastoma project, when we look at overall cancer diagnoses among children aged 0 to 14, we can see that leukemia, lymphoma, and central nervous system tumors dominate the diagnosis among children of this age. And hepatic tumors are very, very rare, representing about 1 to 2% of all childhood cancer diagnoses in this age group. So when we look at age-specific incidence of hepatoblastoma, we can see, again, it is very rare. White children in infancy have about an incidence rate of 12 per million children. That rate is lower among Black children and slightly higher among Asian and Pacific Islander children. And among all age groups, we can see that hepatoblastoma is diagnosed mostly in the first few years of life, with incidence very, very low among children older than 6. And there are also some differences in ethnic group. So we can see that Hispanic children have higher incidence rates in infancy and slightly higher rates than non-Hispanic whites in most age groups, leading to the lowest incidence, again, around 5 to 6 years of age. Our group recently undertook an analysis of incidence trends among childhood cancer cases using the cancer incidence on 5 continents data. And when we examined the childhood cancer tumor types that were, the incidence was rising the fastest, we could see in nearly every region of the world that hepatoblastoma is the tumor type that is increasing in incidence the fastest among all tumor types. So that although this tumor is very, very rare, it does increase its importance when we know that the incidence is increasing so rapidly worldwide. I also have an ongoing analysis examining incidence trends in the United States between years 2000 and 2018. And overall, there is a statistically significant increase in incidence in children diagnosed with hepatoblastoma. And that is particularly significant among non-Hispanic Black children, where we can see the average annual percent change is over 4% increasing incidence year over year among those non-Hispanic Black children. Among the notable factors that has long been known about the etiology of hepatoblastoma is that it's highly associated with birth weight, and there is a trend with decreasing birth weight, increasing risk of hepatoblastoma. So we can see, compared to normal birth weight children, that would be children born at 2,500 grams or more, children born between 2,000 and less than 2,500 grams have a 1.5-fold increased risk of hepatoblastoma. That rises to about threefold increased risk when we examine children born between 1,500 and less than 2,000 grams of birth weight. And then when we look at the very low birth weight children, you can see a 17-fold increased risk of hepatoblastoma for children born between 350 grams and less than 1,500 grams. It has also been appreciated more recently, the association between congenital anomalies and childhood cancer. And this is a recent paper published in 2019 by Philip Lupo and colleagues out of Baylor College of Medicine. And among all tumor types, hepatoblastoma was the type associated most strongly with a wide array of congenital anomalies. So birth with any chromosomal anomaly, digestive system defects, respiratory, circulatory system defects, eye defects, and ear, face, or neck defects were associated with hazard ratios from 5 to more than 10, representing a very strong increased risk of hepatoblastoma among these children born with congenital anomalies. So one area that has been lacking in terms of a lot of data has been hepatoblastoma survivorship. This is partially due because of its rarity. There is some indication that cases diagnosed with hepatic tumors are at increased risk for hospitalization of liver disease, hospitalization for endocrine disorders, and additionally hospitalization for any reason compared to population-based controls. These are data out of a collaboration of Nordic countries that included just over 200 cases at most, and in the analysis of hospitalization for any reason, just over 100 cases. So the data are scant for the survivorship experience among these cases. Among the things that we really have limited data on is the frequency of long-term mortality and the causes of long-term mortality events, the rate and type of second cancers experienced by this population, the rate of liver transplantation, and other long-term cardiovascular, GI, and psychosocial outcomes. And one of the hints that we have from the limited data is that the risk of second cancer is strikingly high and potentially dramatically increasing around 20 years past diagnosis. You can see here hepatoblastoma cases represented in the black line. But again, this analysis was based on very few numbers of cases and very few numbers of second malignancy events. So there's still a lot to discover in terms of the survivorship experience in this group of cases. So that's what I've undertaken using the resources of the Children's Oncology Group. This is a collaborative group of nearly 200 hospitals in the US and Canada that joined several decades ago to form a clinical trial network to enable research among these very rare tumor types. So our proposal was to examine all hepatoblastoma cases recorded since the inception of COG, and indeed also its predecessors, including POG and CCG. Any hepatoblastoma case that was recorded with name and date of birth, we have collected those data and linked to the National Death Index to examine long-term mortality among these cases. So for this project, we have data from several different COG and CCG protocols. You can see we were able to obtain data from 2 early CCG protocols that collected cases diagnosed in the 70s and early 80s. We also have data from a biology protocol led by Dr. Gail Tomlinson from Texas. Additionally, we have data from an epidemiology study led by Dr. Logan Spector here at the U. Those cases were diagnosed between 2000 and 2008. And finally, we have 2 registration protocols, ACCRN07 and Project Every Child, or APC14B1, that have collected name and date of birth for all childhood cancer cases, including hepatoblastoma cases. And in total, we had 1,478 hepatoblastoma cases available for this study. We submitted all of those to NDI that were not missing date of birth, not missing first name, and had at least one initial of their last name. And among these 1,478 cases, there were 1,416 that were recorded to be living in the United States and 62 that resided in Canada or the rest of the world. From COG data, we had information that 153 of these cases were deceased, and we had unknown vital status for 1,325 of these. Among those that were deceased, 130 of these successfully matched to the NDI. 18 US residents did not match, and there were 5 non-US residents who did not match to NDI. And this is not surprising given that NDI collects death data on US residents only. Of those with unknown vital status at the time of linkage, 124 of those did match to the National Death Index. There were 1,144 who did not match and are presumed to be alive, and 57 non-US residents that did not match. So those 62 non-US residents were excluded from analysis. Additionally, there was one case determined to be neuroblastoma. And so our final analytic data set contained 1,415 hepatoblastoma cases. And of those, 271 were deceased during follow-up. Given that much of our population has been diagnosed in recent years, you can see that the follow-up time is skewed toward the 0 to 5 year range. Our median follow-up time is 8 years, with an interquartile range of 2 to 14 years of follow-up for these cases. However, since we do have cases dating back to the late 70s and early 80s, there are some individuals for whom we have between 30 and 40 years of follow-up time. So overall, 19% of this population, or 271 cases, were deceased during the follow-up time. The risk of being deceased during this was associated with a higher age at diagnosis. There was no difference that we determined between male and female cases. We did not see in univariate analyses any difference in mortality among different racial and ethnic groups. And unsurprisingly, there is a strong association between the percent of patients deceased and decade of diagnosis, with those diagnosed in more recent years faring much better in terms of overall survival. So when we examine excess mortality among 1-year survivors, we do see excess mortality from any cause in both male and female patients. Overall, the standardized mortality ratio among all of our patients is around 16 for 1-year survivors. These excess mortality rates are very strong for both cancer and liver cancer. And again, these are 1-year survivors, so some of these mortality events are due to their primary hepatoblastoma. So when we examine 5-year survivors, in which we don't expect to see mortality events due to the primary hepatoblastoma, we do still see excess mortality risk from any cause, and additionally excess mortality from cancer, and in particular liver cancer among male cases who have been diagnosed with hepatoblastoma. Our overall standardized mortality ratio is around 3 for all of our patients. We saw similar rates of excess mortality among male and female patients overall. We do see a higher point estimate for excess mortality among Black cases, but you can see our confidence limits are very wide, representing the fact that we have very few Black patients in our sample. So when we visualize the mortality experience in this cohort of patients, we can see that, again, those diagnosed in the early decades, so we have those diagnosed in the 80s here in red, the very few cases that were diagnosed in the 70s here in blue, and these two groups of patients fare significantly worse than patients diagnosed in the 1990s, 2000s, And we can see those diagnosed in the 2010s so far have a much better survival experience than those diagnosed in any previous decade. It's also notable that many of our long-term mortality events, so mortality occurring more than 5 years after diagnosis, occurred in those diagnosed in the 80s. We don't see many mortality events here in those diagnosed in the 1990s or 2000s, even among those for whom we have 10 to 20, and in some cases, even 30 years of follow-up. And we'll talk about why in a few slides. We do have stage at diagnosis for those diagnosed in the very early studies. We are also working on getting that information for the children diagnosed in later years. So this slide represents those children diagnosed in the CCG protocols from 1979 to 1984. And unsurprisingly, we can see striking differences between children diagnosed with stage 1, 2, 3, and 4 cancer, with a lot of immediate mortality events in those diagnosed with later stage cancers, and better survival overall among those diagnosed with stage 1 and stage 2. And of course, these survival experiences have improved dramatically among all of these cases, among hepatoblastoma cases diagnosed in subsequent decades. But still, even today, the late stage cases experience much higher rates of mortality, unsurprisingly, than those diagnosed in stage 1 or 2. When we examined survival by race and ethnicity, we did not see any statistically significant differences between these groups. You can see that we have few cases. You can see the big jumps in the survival curves among Black children and Hispanic individuals. But overall, it does appear that in the first decade after diagnosis, Asian and Hispanic children seem to fare better than white or Black children. As I mentioned, congenital anomalies are strongly associated with risk of hepatoblastoma. So we examined whether there was any survival difference in children born with birth defects compared with children not having a recorded birth defect. And there is a statistically significant difference in these two curves. And you can see in particular, in the few years immediately following diagnosis, there is a lot of mortality events in children who have birth defects compared with children who were not diagnosed with birth defects. So in our initial Cox proportional hazards models, when we look at age at diagnosis, sex, race, ethnicity, and stage at diagnosis, again, unsurprisingly, stage is strongly associated with risk of death from hepatoblastoma. And adjusting for all of these variables, Black race is also associated with over a 2-fold increased risk of mortality from hepatoblastoma. But again, when we look at survival by decade of diagnosis, a lot of these late mortality events are in the very early cases. We actually don't see a lot of late mortality among cases diagnosed in the 1990s or 2000s. And although we don't have much follow-up time yet in those diagnosed in the 2010s, we also did not observe any late mortality events past 5 years of diagnosis among those cases. And this is starting to be a consistent observation in the few other studies that have examined mortality events among hepatoblastoma cases. This analysis was just published this year. The study looked at 151 cases diagnosed between 1990 and 2017. This was a median follow-up time of just over 9 years among these hepatoblastoma cases. All of these cases underwent resection of their primary tumor, and they underwent additionally one of 3 chemotherapy regimens involving either cisplatin alone, cisplatin plus doxorubicin, or cisplatin, doxorubicin, and carboplatin. And among 2-year survivors of hepatoblastoma, the 5-year event-free survival was 96.6%, and the 5-year overall survival was 98.7%. And you can see in these curves, this study also did not observe very many late mortality events. So that's really great news for this group of survivors. And we hope to continue to accumulate more data as this cohort ages. We will continue to do linkages to NDI and other available resources. However, it's important to note that survival and mortality are not the only experiences that this cohort of patients might be experiencing. So those early patients were treated with a much more robust regimen of chemotherapies. There were many more chemotherapy agents involved in the treatment of these cases. Stage 1 patients from those early protocols received surgery plus vincristine, Cytoxan, doxorubicin, and 5-fluorouracil. Stage 2 patients received surgery plus radiation, Cytoxan, and the C5b regimen, which is cisplatin, 5-fluorouracil, and vincristine. Stage 3 and 4 cases received bleomycin, Cytoxan, C5bd, which is cisplatin, 5-fluorouracil, vincristine, and doxorubicin, and radiation. And this is very notable because radiation is not standard treatment for hepatoblastoma cases currently. And this might be why we saw so much more marked late mortality events in those cases diagnosed during these years compared to cases diagnosed in later years. The primary COG protocol for cases diagnosed in the late 80s and early 90s was the C5b or cisplatin, 5-fluorouracil, and vincristine compared to cisplatin plus doxorubicin. In the late 90s and early 2000s, stage 1-2 patients were treated with the C5b protocol with or without the addition of amifostine, which is an agent aimed at reducing the platinum-based therapy toxicities. And stage 3-4 cases received cisplatin and carboplatin with or without the addition of amifostine. And more recently, COG patients among those who are low risk received surgery plus the C5b protocol. Intermediate risk patients receive surgery plus C5bd, and high risk patients receive C5bd and an additional 2 agents at the beginning of their therapy. So you can see that for the vast majority of patients, they received platinum-based chemotherapies, at least 1 agent. Some patients have received 2 platinum-based therapy agents, and many of them also received doxorubicin, which is an anthracycline. So there may be events in this group of patients that are due to these agents that are not captured in mortality events. So for instance, cumulative dose of doxorubicin has been shown to be associated with decreased left ventricular contractility. This is a function of both dose, and there were differences seen among male and female patients. And doxorubicin, which is an anthracycline, which is as a class associated with cardiotoxicity, has also been associated with both cardiac events overall. You can see in the pink line here, these are patients that received anthracyclines only and no radiation. There was an 8.3 cumulative incidence of any cardiac event among this cohort of childhood cancer survivors, including hepatoblastoma and other cases, as well as a 7.5% cumulative incidence of congestive heart failure among children who received anthracyclines. Additionally, cumulative anthracycline dose was strongly associated with hazard of both any cardiac event and congestive heart failure. There's also many known associations between platinum-based therapy and ototoxicity. So in this cohort of 11,000 childhood cancer cases diagnosed between 1987 and 2016. There is an increased risk of hearing loss that required hearing amplification devices after cisplatin therapy, and that is after adjustment for other important variables, including cumulative radiation dose to the ear. And in the same cohort of cases, hepatoblastoma cases had the highest cumulative incidence of hearing loss that required amplification devices. In the follow-up time, the cumulative incidence among hepatoblastoma survivors was 16.2%. So this just shows that given the regimen of chemotherapy that these patients generally undergo, there may be many factors affecting their survivorship experience that aren't fully captured in mortality linkages and mortality events. So there's still a lot to uncover here in terms of the survivorship experience among hepatoblastoma cases. And we do plan to also link to the VPR, which is the virtual pooled registry, to uncover any second malignancies in that cohort, as well as the liver transplantation database to examine rates and outcomes from transplant among those cases. Those are some future directions of that work. Now I'll move on to talking about a second project, which is just getting started. This is on socioeconomic status and ALL outcomes. This is a project that I have developed over the last couple of years and put in for NIH R01 funding. It received a fundable score in June of this year, and we expect funding to come through in the next few months. So we're very excited to get this study going. And as you might recall, leukemia as a group is the most common type of childhood cancer diagnosed among children 0 to 14. There are two main types of leukemia diagnoses: ALL, which is acute lymphoblastic leukemia, and AML, which is acute myeloid leukemia. And you can see when we look at the age-specific incidence curves that not only is ALL much more common generally than AML, but there's this peak incidence around age 1 to 5, where the incidence rate is much higher than at any other point in life or in childhood. When we examine ALL incidence by race, we can see that non-Hispanic white children have higher incidence rates across all ages compared to Black and Asian and Pacific Islander children. And in particular, Black children have approximately half the incidence rates compared to white children at almost every age. When we examine ALL incidence by ethnicity, we can see that Hispanic children have higher incidence rates across almost all ages compared to non-Hispanic white children. Additionally, there is evidence that incidence trends are increasing more rapidly among non-Hispanic Black, Asian Pacific Islander, and Hispanic children for ALL cases. There are increased average annual percent changes among non-Hispanic white children, but those are much smaller and not statistically significant. So not only, especially for Hispanic children, already we see that their incidence rates are higher than non-Hispanic white children, but they are increasing more rapidly than non-Hispanic white children. Additionally, there are some well-known survival disparities among many tumor types, but in particular, ALL, we can see that several different studies have shown higher survival rates among white children compared to Black and Hispanic children. This is true if we look at 5-year overall survival or 5-year event-free survival. It appears that Asian children statistically have very similar survival rates compared to white children, but the disparities between Black and Hispanic children compared to non-Hispanic white children are very striking. There are some reports that these disparities are at least in part, associated with socioeconomic status. So this was an analysis of SEER data examining early death and the association with socioeconomic status. So among children with hematologic malignancies, leukemia included, of course, early death, which was defined as death within 1 month of diagnosis, was associated with Black race, Hispanic ethnicity, lower education, poverty, language isolation, unemployment, and lower income. Additionally, the survival disparities remain in place even with adjustment for some socioeconomic variables. So the survival rates do attenuate some with adjustment for health insurance and small area deprivation index. So you can see among children diagnosed with leukemia and lymphoma, the unadjusted hazard ratios for mortality are about 1.57, with adjustment for sex, age at diagnosis, statistical area, and other conditions. This attenuates slightly, with some further attenuation after adjustment for health insurance and social deprivation index. And with adjustment for both health insurance and the small area deprivation index, the survival disparities remain when we compare Black versus white children. So there are certainly some indications that socioeconomic factors play into the survival disparities that we see, but they do not necessarily account for all of the disparities. This is also true when we examine non-Hispanic, white, and Hispanic children. So Hispanic children, even after adjustment for all of those factors, have a higher risk of mortality, and other children compared to non-Hispanic white children. So another important factor when we think of prognosis and survival is the cytogenetic subtype. So it's well-known characteristic of leukemias in general that there are many different cytogenetic subtypes and that these vary by age at diagnosis. So for instance, among infants, the cytogenetic subtypes are dominated by KMT2A translocations, including the very prevalent KMT2A AFF1. When we look at slightly older children diagnosed in that peak incidence range of 1 to 4, and children age 5 to 9, those children are dominated by the ETV6-RUNX1 subtypes and high hyperdiploidy. Combined, those represent over 75% of cases diagnosed at age 1 to 4, and over 60% of cases diagnosed at age 5 to 9. So this is important because the cytogenetic subtypes are highly relevant prognostic factors. So you can see the ETV6-RUNX1 and high hyperdiploidy subtypes are very favorable in terms of prognosis, whereas MLL translocations, which is the same as KMT2A translocations, confer poor prognosis, as well as hypodiploidy and the BCR-ABL translocation subtypes. And the reason this is relevant when we are talking about survival disparities is that there's also some evidence that those subtypes, risk for certain subtypes is not the same among white versus non-Hispanic Black and Hispanic children. So for instance, among white children, there's a higher proportion of cases diagnosed with the ETV6-RUNX1 subtype. So in 2 separate case cohorts, one from California and one examining cases from all over the US, white patients had a higher percentage of the ETV6-RUNX1 subtype. Among Black cases, a lower percentage was diagnosed with the ETV6-RUNX1 subtype, and that was also true for Hispanic cases. The high hyperdiploidy subtype is another that is very favorable in terms of prognosis. Here we see that the proportion of Hispanic cases was slightly higher than other racial and ethnic groups for the high hyperdiploidy subtype, with white cases being intermediate. But again, Black cases have a much lower frequency of this very favorable subtype than white or Hispanic cases. Additionally, the BCR-ABL subtype, which confers very poor prognosis, is more likely to be diagnosed among Black children. So there are many indications that socioeconomic status might play into the survival disparities that we observe among white and Black and Hispanic children. But also we see, based on the distribution of biological factors, and in particular here cytogenetic subtype, that there may be roles for these biological factors that are factoring into the survival disparities that we observe as well. So Black children are less likely to be diagnosed with the favorable subtypes and more likely to be diagnosed with the unfavorable subtypes. So really disentangling the pathways of socioeconomic status and biological factors that are contributing to the survival disparities that we observe can help us understand how to begin to improve those survival disparities. And that's what this project aims to do. Again, I've proposed to use the resources of the Children's Oncology Group for this study. So the Children's Oncology Group had a registration protocol, ACCRN 07, affectionately known as CCRN, or the Childhood Cancer Registration Network. This was a registration protocol that was open from December 2007 through December 2017, so 10 full years nearly of registration to this protocol. And the purpose of this protocol was just to register any type of cancer case as a COG institution for research and future contact to enable some of the etiologic and epidemiologic research that isn't necessarily involved at the clinical trial level, but really would need to contact these patients in the future for questionnaire or other data collection. As part of the protocol, basic diagnostic data was collected, as well as basic demographic data to enable future contact, including, importantly for this project, address at diagnosis. And in total, there were over 57,000 registrants of childhood cancer cases on the CCRN protocol. So this project proposes to use those that are primary tumors, US-based, and with a usable address. And in total, that is over 49,000 total cases. So the project aims for this study are to geocode the patients with a valid US address and contextualize that geocoded data with socioeconomic status from small area American Community Survey data. With that socioeconomic status data, we would like to examine the influence of SES, distance to care, and insurance status on the risk of serious adverse events in the over 12,000 acute lymphoblastic leukemia patients for whom we will have data, as well as look at those predictors on the influence of risk of relapse and survival among those patients. So CCRN enrollment in total, again, there are over 49,000 cases with a usable address that we would attempt to geocode. And among those, there are over 15,000 ALL cases, including a large number of Hispanic and Black patients to enable examination among those vulnerable subgroups of patients. So for the geocoding portion of this is really the bulk of the work that will enable us to examine small area socioeconomic status. So what we do with geocoding is attempt to identify the longitude and latitude of each case's address and assign those to a census tract and census block. So census tracts are nested within counties, and they contain on average between 4,000 and 8,000 inhabitants. Census block groups and census blocks are nested within census tracts, and they are much smaller level of area, and each census block on average represents about 100 inhabitants. So that's a very fine level, although it's not individual level data, that represents a very small area of people. So we have actually undergone geocoding for this cohort. We have been able to get started with some support from NCI. So as part of the CCRN protocol, each case and, if available, both parents filled out addresses. So we had up to 3 addresses for each case. And we geocoded the records containing 99,719 records in total for this cohort. So the first phase of geocoding, where all addresses were uploaded into the local composite geocoded, resulted in over 72,000 matches to an address point and over 19,000 matches to a street address. Those were considered good matches. Those are 92% of our total addresses were good matches that didn't need to be further resolved. The others that were matched to a less fine level of detail were reviewed individually and underwent string cleaning to remove elements such as apartment numbers or lot numbers to try and improve the string that was available for automatic geocoding. Those addresses were split into state and family IDs so that duplicate addresses could be compared for inconsistencies and to provide additional information. And then those were manually reviewed to do a final cleaning and resolve as many matches as we could. And this process added 3,321 good matches. So in total, we were able to geocode 95,457 records, or nearly 96% of our total cohort. So we've examined geocoding success by cancer type. You can see that most cancer types, we were able to geocode between 95 and 96% of cases, including the leukemias. We were slightly more successful among cases diagnosed with hepatic tumors, and slightly less successful among the other epithelial and other unspecified cases. Importantly, we wanted to examine geocoding success by race and ethnicity. You can see that for non-Hispanic white, non-Hispanic Black, Asian Pacific Islander, and Hispanic cases, we're very consistent in terms of geocoding success. And we're very strikingly not successful in geocoding the American Indian and Alaska Native groups. This might be due to the particular characteristics of Native land addresses and children who live on Native reservations. This does represent in total less than 300 cases. So this is a small amount of cases, but we have set those aside, and one of the first things we're going to do at the start of this project is to manually go through those cases again and try to resolve some of that data from the American Indian and Alaska Native group. So as I've mentioned, we will have American Community Survey data to measure small area socioeconomic status. So this is done by a factor analysis of these 7 variables that include household income, house value, gross rent, percent of the population living below 150% of the poverty line, percent unemployed, education index, and percent working class. And those are the 7 variables that feed into the socioeconomic status index. Additionally, there are other SES relevant variables that we will have available at the census tract level and the census block level, including at the block level, which again is that very small area level, percent single family homes, percent owner occupied housing units, race distribution, and age distribution of that population. So one of the important things that will feed into this project is the clinical trial data. So among ALL cases that were enrolled on CCRN, we examined how many of them were simultaneously enrolled on the ALL clinical trials that were open during that time. And you can see the title, the clinical trial total accrual in the second to last column, and the total number of cases that were enrolled on these clinical trials and also enrolled on the CCRN protocol. You can see some of these trials opened in dates that were not open to CCRN enrollment, so that accounts for some of the lack of overlap. But also we know that CCRN did not capture all cases enrolled in COG trials, so there is some of that as well. But in total, we have over 12,000 cases of childhood leukemia enrolled on both a clinical trial and the CCRN protocol. And among those, when we look at the number of cases that we successfully geocoded, we have over 11,000 cases that we have successfully geocoded, which will form our effective sample size for this project. So our main outcomes that we're interested in include both short-term toxicities and relapse and survival. So we will get all of this information from the clinical trial data, including all the toxicities listed here, relapse date and relapse site, and date of death. And we will gain that data from both the clinical trial data, but in the final years of the grant, we also plan to link these cases to the National Death Index in a similar way that I spoke of with hepatoblastoma cases, to examine the longer term mortality that might not be captured in the clinical trial data. And what's really unique about this project and makes it one of the most interesting projects that I anticipate might contribute to this body of literature is that we will not only have these socioeconomic and geographic variables, so the small area SES that I spoke about, insurance status from clinical trial data, and also we will calculate distance to care, as we will have the geocoded address and the treatment institution. But we will also be able to factor in biological characteristics that might be driving some of those racial and ethnic disparities that we observe, such as cytogenetics, DNA ploidy, white blood cell count at presentation, age at diagnosis, CNS and testicular involvement, NCI and NCI risk group. Additionally, we have for around 1,800 cases genetic data available, so we will actually also be able for that subset of cases to adjust for the genetic variants that are known to be associated with risk of relapse. And finally, we will have the end of induction minimum residual disease, which will be both a predictor of relapse and survival and an outcome in and of itself. So this really encapsulates the power of this study in terms of what we think we can examine by factoring in both socioeconomic and biological factors to really get at a more fine level of detail when we examine the disparities in racial and ethnic groups in terms of ALL survival. So with that, I'd like to acknowledge all of my collaborators on both of these projects, as well as the Children's Cancer Research Fund and the NCI, which we anticipate funding coming through in the next few months for the socioeconomic status project. And I'd also like to note that there are many, many ways that we can use the CCRN data and the socioeconomic project to enhance our understanding of these issues and look at other tumor types. We can also examine the geocoding data and look at neighborhood walkability, green space, noise pollution, food availability. There are many things that we can do with this that are not currently part of this project that are really wide open to collaboration. And I would love to hear from anyone who might be interested in collaborating on any aspect of these projects. So thank you very much, and I'm happy to take any questions.
Thanks, Erin. That's really exciting, actually. I'm excited about your study. And so if you have questions, feel free to raise your hand. You can put it in the chat if you prefer. I can start, actually. I'm curious how you're going to use the multiple addresses in your approach for this.
Yes. So first, those are not deduplicated. So it's possible that, we have 3 addresses of the same address for the case in both parents. So that is one consideration that we just haven't gotten to yet, as this is just getting off the ground. But we also can use the parent's address information to determine whether the family unit is intact, or whether there might be 2 single parent families. But in terms of determining a final address that we consider the one to assign socioeconomic status, we likely will do some sensitivity analyses and determine if there are disparities if we use one versus another. But also, I would assume that the case's address as recorded in the CCRN protocol would most likely represent the address at which the case spent the most time during that time period. So that is the one we will use if we have that information. But we will look at the impact of those decisions for sure, because it's not necessarily straightforward.
I was hoping one of them was like birth address, but I can see it's more complicated than that.
Wouldn't that be great?
Yeah.
Unfortunately not.
And I'm sorry, it might be really noisy in my background now. So David Largaspada has a question. He asks, what percentage of hepatoblastomas are associated with Beckwith-Wiedemann syndrome? And is there any chance that that is becoming more common with older parents and the use of IVF?
Absolutely. Yeah, that's a really interesting question. So Beckwith-Wiedemann is a known risk factor for hepatoblastoma. In terms of the proportion of cases that have Beckwith-Wiedemann, I don't know that there are solid numbers on that, although we have here locally undergone some analyses on exactly that question recently, and we found that among Beckwith-Wiedemann cases that have a specific imprinting disorder, there were about 3% of our cases that had Beckwith-Wiedemann known variants, and it is likely more because there are both epigenetic and genetic effects that can lead to Beckwith-Wiedemann. So yes, that's certainly a consideration in all of this, and for the hepatoblastoma survival, we will be looking at that to the extent that we can. And yes, I agree that it is likely that Beckwith-Wiedemann incidence is increasing given the known association with IVF. And we know in the last several decades that births resulting from IVF have become more common.
So I had a question as well with the hepatoblastoma work. You showed excess 5-year mortality, and for males, there was the excess for liver cancer, but that wasn't present for females, but they had excess cancer. So what cancers are they getting?
Yeah, that's a good question. There were only 3 non-liver cancer secondary neoplasms, and I'm really sorry, I don't have exactly what those 3 were off the top of my head. There were 10 cancer events. 7 of those were liver cancer, and all of those were in males. So we are looking at small numbers of events. But yes, that is certainly something that we will continue to dig into, as that's one of the most interesting things that come out of this, right? Is we're only capturing those second cancers that were fatal, of course, in this analysis, but looking at what types of cancers are diagnosed in this population is really interesting.
Sorry, I see another question coming in here. If kids get cancer so early, do they have regular development in female reproductive function later in life?
Not always. So yes, a lot of these chemotherapies are toxic in many, many ways and can affect fertility and reproductive function. So it's a major issue among these survivors. A lot of work has gone into just improving survival, of course, but the cost of that has really come out in the last few decades as we've been following these survivors in terms of psychosocial outcomes, the reproductive outcomes. the cardiovascular events that are occurring in these patients and the second malignancies. So yes, there are definitely reproductive harms depending on the chemotherapies and the type of tumor originally diagnosed.
And there was a follow-up to that. Will you be able to get those data as part of this research project?
So possibly for a subset, we don't have funding right now to contact these individuals, but for some of these, I mentioned Dr. Logan Spector's epidemiology study that was conducted here. We did, conduct questionnaires with that population as part of that original study, and I believe have permission to follow up with those individuals, so we could collect another round of data collection, as well as the participants from CCRN that were diagnosed more recently. Those patients have all consented to recontact. I highly doubt we could track down the individuals diagnosed in the 70s and 80s, but for a subset of those diagnosed in the 2000s and beyond, I imagine that with funding, we could do that. And that's certainly an interest of ours and something that we'd like to pursue.
Thanks. I think, Jaime, I think Jaime has a question, and I don't know how to unmute him, but I don't know. Can we get Jaime?
He typed it in the chat as well.
Yeah, and said he would follow up, but I don't know, is there a way to unmute? If not, then he can just follow up separately with Logan and Erin while we try to figure that out.
Here he is.
Oh, I
awesome.
got unmuted. Thank you. So I apologize because I know we only have like 4 minutes and probably all of us have to go to another thing. What I was fascinated by the low birth weights thing. And so my one question is, if you follow the evolution of human society, the humans in general have gotten much larger over the last 400 or 500 years, and probably, tens of thousands of years. So I wonder what happened when humans were small and birth weights were tiny, where a lot of things that we would say were early deaths due to these tumors, and there just wasn't the technology to diagnose them because, they would say that the devil got the baby. Or do you think there's something unique about, as humans have gotten larger, when they are undersized for our current size potential, is that creating issues with all of the other things that you've identified that may have to do with, undernutrition or drug abuse or whatever are all the other factors that come into low birth weights?
Right, it's a really interesting question. And the low birth weight observations have driven a lot of research, including Logan's epidemiology study. And so there are a few things going on. One is the association with birth defects. And we know that children with birth defects are more likely to be born premature. And when we adjust for both low birth weight and birth defects, the low birth weight association does attenuate. It doesn't go away completely, but it is attenuated. So there's that coming into play. But also the main theories on the low birth weight association is that it may be NICU exposures. So oxygen supplementation, potentially oxidative stress resulting from that is potentially driving a lot of those observations. And one thing that we do know that is interesting is that children born low birth weight and very low birth weight are more likely to be diagnosed with hepatoblastoma at later ages, so age 2 or 3 compared to infancy.
Thanks, fascinating.
Thanks.
Have Jaime set up to ask this question. We can have this be the final question.
Oh, I think Jaime just finished his question. So I think that is probably the end of our time today. Erin, this was great. We're so excited about your new work. I think there's going to be great opportunities to collaborate, and really trainees have great opportunities to do some work on this project as it develops. So thank you, everyone, and have a great Tuesday.
Thank you.
Thanks, Erin.